All right, so it's recording now. Okay, so today we are going to talk about cochlear implantation in labyrinthitis ossificans. This is a build-up from the case that we discussed the other Friday. And labyrinthitis ossificans refers to abnormal growth of bone within the perilymphatic spaces of the labyrinth. It's commonly associated with profound deafness and vestibular hypofunction. And recent case reports report that up to 13% of all cochlear implant patients have some degree of labyrinthitis ossificans. While this was an absolute contraindication to cochlear implantation before, it's no longer an absolute contraindication. And this is because we now understand the anatomy of the cochlea better with newer advanced imaging modalities and newer surgical techniques, plus specially designed electrodes. In some patients, you're actually able to proceed with cochlear implantation with acceptable results. The commonest causes of labyrinthitis ossificans in up to 75% is bacterial meningitis. Other common causes are autoimmune inner ear disease, labyrinthine fractures, intracochlear hemorrhage, otitis media, loss of labyrinthine blood supply, advanced sclerosis, and also after translab procedures, especially for vestibular schwannomas. Other causes include sickle cell anemia, leukemia. There have been a few case reports of rubella vaccination leading to ossification of the cochlea, Paget's disease, fibrous dysplasia, and case reports in Usher and Noonan syndrome have also been documented. So the anatomy of the labyrinth is made of 3 layers of bone. We have an endosteal layer, an echondral layer, and a periosteal layer. The endosteal layer is a thin layer of bone cells that have gaps between them. The echondral layer forms in utero and is usually achieved adult size by 23 weeks of amenorrhea. It undergoes minimal remodeling after that. And then the periosteal layer has lamellar bone and can repair and remodel even after trauma. The first 2 layers do not remodel after trauma. And the bony labyrinth usually will retain the same size and patterns throughout the life course of a person. Now, in labyrinthitis ossificans, new disorganized bone forms within the spaces in the labyrinth, and this leads to the obliteration of the spaces within the labyrinth. And the fibrosis usually starts from the base of the cochlea to the apex from the base of the cochlea to the apex, and it will start in the scala tympani of the basal tongue, move to the scala vestibuli of the basal tongue, then progress to the middle tongue, but still starting from the scala tympani to the scala vestibuli, and then the apical tongue ossifies last. Progression from inflammation to complete obliteration is variable, and you cannot predict if it will take just a few weeks to months, and in some reports even it can take up to years to get to complete obliteration of the cochlea. This occurs in 3 phases. We have the acute or labyrinthitic phase, and this involves inflammation of the intracochlear tissues. Usually you'll have a purulent effusion that will fill the perilymphatic spaces. It will have deposition of fibrin and granulation tissue. This is common in the acute conditions like otitis media, in meningitis, and even in trauma. Next, we'll have a fibrotic phase, which can be decided as the early fibrotic or late fibrotic phases. In early fibrotic phase, we have collagen deposition and angiogenesis in that fibrotic tissue. In the late phase, we start getting deposition of new bone into the scar tissue. Bone remodeling occurs with resorption of the disorganized bone, and this gets replaced with new bone. The duration for this is also variable and can take between 6 months up to 1 year. And then the final phase, which is the ossifying phase, this is when now we have complete bony occlusion of the cochlea, and two types of bone can form in this phase. We can have metaplastic bone or osteoplastic bone. Either can occur in patients, that it doesn't have to be one or the other, and we cannot predict what type of bone you will find at surgery. The metaplastic bone is highly cellular, and you have no osteoblasts or lamellar bone structure that you'd expect in a normal cochlea. And this is usually due to loss of cochlear blood supply and ossification starting from scar tissue in the labyrinth. While the osteoplastic bone has low cellularity, will have osteoblasts and it has some sort of lamellar structure. It will tend to extend from the endosteum that is lining the otic capsule to the center of the spaces within the labyrinth. But a patient can have any type of this, and you cannot predict what type you will find. So in recent reports are showing that labyrinthitis ossificans is becoming challenging for cochlear implant surgeons because we are identifying it more, and early identification is key for better outcomes. As surgeons, we need to evaluate the presence of labyrinthitis ossificans, but also assess the extent of ossification. This can be done with use of CT and MRI, and these help us to make timely decisions on when we can implant so that we don't miss the window. The more you wait, the harder and more complex the surgery becomes, and that's going to affect your decisions on the technique and the type of implant, as we shall see. So audiology is also important. Commonly we say these people are going to have a sensory neural hearing loss. It's variable degrees of the sensory neural hearing loss. In some patients, in most patients, it's profound. However, some reports of a severe to profound loss have been reported. The protocols differ in various centers. There are patients that we know are at high risk of developing labyrinthitis ossificans. However, there are no clear guidelines on when would you repeat the audiology, especially in post-meningitic patients, patients with autoimmune inner ear disease, patients with cochlear hemorrhage and fractures. In autoimmune inner ear disease is important because it's the only cause of labyrinthitis ossificans that has a bit of reversibility. Reports show that if treatment is started early, you can actually either halt or reverse the fibrotic phases of the disease, especially if complete ossification has not yet occurred. Some centers will suggest screening audiograms. In one center, a suggestion was done after the patient has had their initial assaults, for example, after meningitis, and we have imaging that doesn't show ossification, to try and catch the drop in hearing. They are suggesting screening at 1, 2, 3, 6, and 1 year after the insult. And if at any one of these tests you have more than 30 decibels of hearing loss or a progressive hearing loss, then you need to get imaging to evaluate for ossification. And like I said, this is not standard, and different centers have different protocols on how this is managed. In the management, a first diagnostic workup is recommended. Usually we'll use a CT scan, a high resolution CT scan. It will help us measure the extent of ossification, but also these images can be used by different cochlear implant companies to measure the scala length. So some companies are able to actually measure the parted duct length of either the scala media, the scala tympani, or the scala vestibuli. Urgent MRI is also important. And if we suspect autoimmune inner ear disease, we need urgent consultation with immunology so that if it's still reversible, we can catch it while it's reversible. In autoimmune inner ear disease, if there is fibrosis and we don't have ossification yet, this is actually reversible, and reports show that patients have improved hearing after this. So on MRI, on a T1 weighted image with gadolinium in acute labyrinthitis, you will be able to pick up increased enhancement of the labyrinthine fluids. On a T2 weighted MRI, this is important after the ossification has started. It will show reduced fluid distribution in the cochlea, and it's more sensitive than CT for detecting cochlear lumen narrowing or even obliteration. On a high resolution CT scan, we can detect intracochlear opacification with a sensitivity of between 62 to 95%. Sometimes reformats are suggested around the basal turn of the cochlea or even the modulus to try and assess the spaces better. But also as a screen on CT scan, we can use the lateral semicircular canal. If ossification of the labyrinth is occurring, case reports have shown that this sometimes will start from either the lateral semicircular canal or the superior dome of the superior semicircular canal, especially in meningitis. So if this is detected on CT, then this patient is at a high risk of getting an ossification of their cochlea. A combination of both high resolution CT and MRI increases the sensitivity of detecting early ossification by more than 90%. And different grades have been developed to try and grade labyrinthitis ossificans, but we need to know that even in the same patient, you can have different extents of ossification between ears. Different grades both by radiology and surgeons have been suggested over the years. And the main reason why the grading is used is to try and guide surgical approach, to try and plan possible techniques, and also electrode insertion. So there is this classification where a grade 1 ossification, we can have a 1A where the opacification is only at the round window, or a 1B where opacification is extending from the round window up to between a third and a half of the basal turn. This is very radiological, and sometimes the radiologist can pick this out, especially if they do 3D formats of the cochlea. You can have a grade 2 opacification where opacification is now extending to the entire basal turn of the cochlea. However, the ascending part of the basal turn, the middle turn, and apical turn are patent, and the scala vestibuli of the basal turn is also still patent. We can have a grade 3 opacification where the entire basal turn is opacified. This is both the basal turn and the basal turn, the scala tympani and the scala vestibuli of the basal turn are completely opacified. However, the middle turn and the apical turn are still patent. And then a grade 4 is where we have total opacification of the cochlea. So on this cochlea, on this such cochleas, there is no signal at all. Simpler classifications have been used by surgeons where they'll either describe a parted cochlea, a partially obliterated cochlea, and a totally obliterated cochlea as grade 1, grade 2, or grade 3. And this is simpler for the surgeon, but also as we cancel the patient's unexpected benefits. So on CT scan, we want to see cuts that are looking at the basal turn of the cochlea. We can see this is a high resolution temporal bone CT. We are looking at the right ear, and we can see the basal turn. We can see the pocket of the round window niche, and we can see the normal basal turn of the cochlea. The basal turn in B starts to narrow a bit. You still have a bit of patency, but it starts to narrow. In C, you have less patency. In D, there is hardly anything, and then completely opacified cochlea. You can actually not detect a signal in the basal time, while you can detect where the round window niche is, the air pocket in the round window niche, but you cannot see the basal time of the cochlea. So this is commonly used by the radiologists. They'll use grades 1, 0, where you have a normal cochlea, all the way to grade 4. This image is also just showing us opacification of the cochlea. We can see the round window niche on the right side, but the basal tan is partially opacified, and we can hardly tell the middle and apical tan or even delineate the anatomy of the modulus on this side. On the left side, we can appreciate obliteration of the dome of the lateral semicircular canal and even part of the vestibule in this patient that had bilateral labyrinthitis ossificans. It can occur in just one ear. For example, this patient on the right side, we have opacification. We cannot clearly delineate the basal tan and the middle tan. We can see the canal of the modulus, but we cannot see the other structures clearly, versus the left side where you can actually appreciate the basal tan, you have the middle tan and the apical tan that look patterned. So it's possible for a patient to have labyrinthitis ossificans in just one ear. And then on MRI for labyrinthitis ossificans, you're looking for a fluid signal within the cochlea. You're looking for a fluid signal within the cochlea, and you're looking for a fluid signal within the cochlea, and on this scan, on the right side, you can see the lateral semicircular canal intensity on the axial part. We can see the lateral semicircular canal fluid intensity is normal. We can see our internal auditory canal, but if we compare to the left side, you have no fluid signal in the cochlea or even the semicircular canals, while you can actually see your nerve pattern. So this is important as you're planning for surgery for your patient. So cochlear implantation in of labyrinthitis ossificans, there are special considerations that we have to think about. One, for the surgeon, you need to think of surgical access. Are you planning to do a standard posterior tympanotomy, as with the usual cochlear implant surgeries? Will you do a transcanal articotomy or a subtotal petrosectomy? You also need to plan what will the extent of drilling be. Are you going to access the cochlea through a round window approach? Will you need the basal tan drill out, a middle tan drill out, or complete drill out of all the tans of the cochlea? And we are going to look at this in detail. It's also important for the surgeon as you pick your electrode arrays. Are you using a standard electrode? Are you using a compressed electrode? Some companies have double array electrodes, not so popular, but they're still available. And then some companies have the untested electrode, which can be used to test functionality of the spiral ganglion before you actually implant. You also need to think about where you're going to insert your electrode. Will it be a scalar tympani insertion, or are we thinking about a scalar vestibuli, also known as the vestibular duct insertion? Extent of electrode insertion is variable. Are you able to achieve complete insertion or incomplete insertion, based on how much classification you have? So important for us is to just remember the anatomy of your scala. On the picture on the right, on the left of the screen, we have the round window, and we can see blue is the scalar tympani, green is the scalar media, and then orange is the scalar vestibuli. It's important to appreciate that while the round window niche is drilled away, immediately anterior inferior, the scalar tympani is going to slope inferiorly. The scalar media will be immediately superior to your round window, and then anterosuperior to your round window in this direction, you meet the scala vestibuli. And this is important for us to remember. Sometimes they refer to the scala media as a hook around your round window so that you know where not to damage it from. And then the middle ear anatomy, that's still important for us to appreciate. If this is our round window, we'll have a basal turn, we have the middle turn and the apical turn. It's important to appreciate the relationship between the oval window, the anterior end of the oval window of the annular ligament with the middle turn, but also important for us to appreciate the relationship of the tensor tympani with the apical turn around here. This is a cadaveric dissection of the left ear, and we can see our round window, we have the basal turn. It's important for us to remember that the distance from the round window to the internal carotid artery in many patients is between 8 to 10 millimeters. So we need to be cognizant of that. In some patients, you might have a dehiscent internal carotid artery or aberrant, where it's actually more into the middle ear space. Then the relationship of our middle turn to the stapes footplate, and then the apical turn. In this cadaveric dissection, the facial nerve and the tensor tympani have been drilled out. So the surgical steps, initial steps are similar to a standard cochlear implant surgery. We'll plan our post-auricular incision and placement of the external of the device at least 45 degrees angled up, so that we can allow a patient to wear glasses, but also so that our processor, speech processor and the coil are not overlapping each other. And incisions, newer incisions now are variable, and different surgeons prefer different types of incisions. You can have a standard retroauricular incision. We may have a wide C-shaped incision, post-auricular incision, which might be preferred, especially for if a subtotal petrosectomy is planned, or if a patient has more than a grade 3 opacification. We can have a lazy S incision. We can also have minimal access double incisions. The minimal access double incisions, yes, are more cosmetic, but not very popular among many surgeons, because surgeons do not like having an incision directly over the device. So we'll do our standard canal wall-up mastoidectomy, do a posterior tympanotomy, and the goal for the posterior tympanotomy is to be able to identify your round window niche. So you need to extend your posterior tympanotomy so that you clear landmarks. You're going to have your incus, a short process of incus, which will point to the facial nerve here. You need to see your incudostapedial joint. You might see the stapedial tendon as it comes from the pyramid, and then about 2 to 3 millimeters inferiorly, you're going to see the round window niche in this area. In some patients, you might have a membrane over the round window niche. Sometimes it's a bit fibrotic. This is important because you need to remember that's not the true round window membrane. It will look more pink, more vascularized, with a continuous vascularization from the promontory, and this can be removed with a pick. Until you have clear view of the round window niche, then you can drill away the round window niche overhang until you see that clear membrane. It's important not to incise the membrane until you have clear visibility of the membrane, so not blind poking. And then we'll drill a well for the device. This is also manufacturer dependent. Usually they will provide a template to help us size the pocket very well. And then the best position to open the round window membrane is anterior. Device can be inserted. Now, special considerations: if we have labyrinthitis ossificans, we have new sites that we need to think about, because our standard access of the round window might not be accessible. So we can do a scala tympani cochleostomy. We can do a scala vestibuli cochleostomy of the basal turn. We can do a middle tongue cochleostomy, and we can also do an apical tongue cochleostomy. So the inferior cochleostomy, also known as a scalar tympanic cochleostomy, we said that the basilar membrane hooks around the round window. So our scalar tympanic cochleostomy, we drill anteroinferior to your round window membrane, and this will help you expose your scalar tympani. When you encounter, it's important not to drill directly into the inner ear and try to expose the periosteum. The periosteum can then be opened with a fine needle, and insertion of the electrode can be done. This insertion has, if you find a patent scalar tympani, it has the least resistance because you're going to have straight insertion. You've eliminated the curve of the basal tongue. So when you're drilling the cochleostomy, the direction is important. Don't drill directly to the inner ear, but you drill anteroinferiorly to the position of your round window, and avoid the dotted line, because the dotted line shows where your basilar membrane is. So the picture is showing the same thing. If you do the inferior cochleostomy and you find bone, solid bone, as in this picture, then we plan for a basal tongue drill out. Many times you're going to find uncalcified fibrotic tissue, or you might even find bone, but because it's disorganized fibrotic tissue and bone, sometimes you're able to pick this out with a small rasp or a pick as you continue drilling. It's important to have copious irrigation so that it improves your visibility. And then you follow chalky white bone. It will look different from the usual bone that you see on your promontory. Important is for us to remember the relationship, the distance from the round window to the internal carotid canal, which is about 8 to 10 millimeters. So drilling beyond 8 millimeters poses risk to injuring your internal carotid artery. If you do find a patent canal, like in the picture below, some companies have a test electrode that you can insert to assess the length of electrode that you need, or even the patency. Then you go ahead and insert your electrode. Important as we insert the electrode is to ensure that we are not forcing it in, as this will just lead to rollover of the electrode. Some studies report inserting the electrode and leaving the stylet in to try and give rigidity to the electrode, but the results are variable for leaving the stylet in. If the basal tongue of the scalar tympani is completely ossified, then another option we have is a scalar vestibuli cochleostomy. So if this is our round window, our scalar tympani, we said we drill antero-inferior. For scalar vestibuli, we drill antero-superior, about 1 millimeter antero-superior to the round window. We don't drill immediately anterior, we don't drill immediately superior, because the scalar media is hooking around our round window. If we find a lumen, and usually this lumen might be patent, then we can have full electrode insertion in the scalar vestibuli. This is a temporal bone drill out, just helping us appreciate the relationship of our scalar tympani with the spiral lamina and then the scalar vestibuli. Many times, if your scalar vestibuli is patent, full electrode insertion is actually possible, and patients that get scalar vestibuli insertion in labyrinthitis ossificans actually have comparable speech outcomes to patients that have had scalar tympani insertion. However, if we find this also ossified, then we have an option of a middle tongue drill out. This is not so popular anymore because of the difficulty access to that region. You The few case reports that I found report using a double array device to insert in the middle tongue. And the idea behind this is to try and get as many usable electrodes within the cochlea, as this provides a better audiological outcome. For middle tongue drill out, access is very important because we need full access to the oval window. We remove the incus, so we separate the incudostapedio joint and take out the incus. We remove the incus buttress, take off the stapes superstructure so that we have full view of the oval window. You maintain the sputum, but also in some case reports, they do a subtotal petrosectomy to have better access and to avoid drilling under a tunnel, because we risk injuring the facial nerve, but we also risk injury to the internal carotid artery. So the cadaveric picture is showing the second time cochleostomy. Important is to note in this picture that the stapes was not removed, but important for us to note that we drill immediately anterior to the anterior cross of the foot plate, 1 millimeter. Beyond 1 millimeter, we end up in the scala vestibuli of the middle tongue. So immediately at some call it the annular ligament of the stapes foot plate, the anterior annular ligament of the stapes foot plate. If we drill there, we should end up in the scala tympani of the basal tongue. It's not a problem if we end up in the scala vestibuli of the basal tongue, but once we have a patent canal, then this is where we shall do the insertion of the second electrode. Important is we must always remain inferior to the cochlear reform process, because this helps us protect the facial nerve, which is here, the tympanic segment of the facial nerve, but also the geniculate ganglion, which is in this area. So we never work superior to the cochlear reform process. The tensor tympani canal is also an important landmark that we need to keep sight of. So when you do a subtotal petrosectomy, you have better visibility of this area. In the picture, this is a surgical picture of the left ear, and we can see our facial nerves and then our second tongue drill out. This is the foot plate over here, and then we have the basal tongue drill out, and the electrode was inserted here retrograde into the second tongue drill out. And for double array electrodes, an electrode can be inserted into the basal tongue as far as possible with as minimal resistance as possible, or it can be inserted into the middle tongue as far as possible with minimal resistance. And the idea behind this is to have as many contact points of the electrodes with the cochlea. And it's important to have an experienced audiologist, because the marking for such implantation is done anatomically based on where the electrodes are. We can also have an apical drill out. This is reported in some literature. It's important, the important landmarks, still you need good access of your middle ear space. You need to identify your facial nerve, keep the cochlear reform process in view. Anterior to the stapes foot plate, but inferior to the tensor tympani canal. That's where we shall drill to try and access the apical tongue. It's important not to move superiorly, because we risk damaging the facial nerve and the geniculate ganglion, but also not far anteriorly, because we have the carotid artery. So for apical tongue drill outs, double array electrodes can be used, where the one array is inserted into the apical tongue drill out, and then a second array can be inserted into our basal tongue drill out. Important is that two electrodes should not overlap, because they will not be usable, and they should not be forcefully inserted. You insert the electrode as fast smoothly as you can to get a better response. I found this algorithm in a paper published from NYU. as a general guide for how you would approach an ossified cochlea. So very important is to evaluate the most recent imaging over and over again. Your first plan is always to attempt a scalar tympani cochleostomy if the round window is not accessible to you. If the scalar tympani is encountered and is obstructed, then we are going to drill out the basal tongue up to the ascending part of the basal tongue of the scalar tympani. If we find the patent lumen, then you have a test electrode accessible to you. We insert the test electrode. If we have successful insertion of the test electrode, we insert our cochlear implant electrode into the scalar tympani. If the test electrode insertion is unsuccessful and meeting resistance, then we are going to attempt a scalar vestibuli insertion. That means we don't have a patent basal tongue scalar tympani. So if we find the scalar vestibuli is patent, then we shall insert our electrode into the scalar vestibuli. If the scalar vestibuli is obstructed, then this is when we consider the advanced options, either to get a double array electrode if it's available to you. Some companies have medium or compressed electrodes, which are slightly shorter. We can consider insertion of the electrode into the basal tongue only, or have a total drill out of the entire cochlea. Insertion into the basal tongue only leads to incomplete insertion, and this has been shown to have poorer audiologic outcomes compared to using either a double array or a medium compressed electrode, where you're going to have full insertion of all active electrodes. Closure. It's important to make sure that each cochleostomy site is tightly packed. You can use either periosteum or fascia. Some papers report using muscle, the temporalis region, and this is to hopefully secure the electrode, but also to avoid electrode migration. Wound closure and electrode testing is done as per the standard protocols for each of the electrode companies. And then for many surgeons, they prefer to have a standards view X-ray done intra-op. Some will ask for a standards view or a slightly tilted transorbital X-ray to try and understand how much of the cochlear implant is actually in the cochlea, and also to rule out any tip rollovers. The outcomes for CI in an ossified cochlea are usually difficult to predict because the degree of ossification that is seen on imaging might not predict the auditory outcomes. Many times we are unable to repeat imaging just before surgery is done, but also it is thought that some of the primary diseases may affect not just the perilymphatic space, but also the cochlear neurostructures and the central auditory pathways. Auditory outcomes are variable, with most papers reporting that for a patient that is profoundly deaf, they will have slightly better outcomes after implantation versus no implantation at all. So many centers now give a chance to patients that have ossified cochleas. They will give them a chance at cochlear implantation. However, the patient or the parents of the child need to have realistic expectations post-implantation. Complete cochlear opacification or modular opacification has been shown to have poorer scores audiologically. Comparing sinus tympani versus sinus vestibuli insertion of the basal tongue in Labyrinthitis ossificans actually shows similar audiologic outcomes at higher. And then use of single versus double array electrodes. In children, results are comparable, whether you use a double array or a single array electrode, while in adults, adults tend to do better with double array electrodes, and it is thought this could be because you have more active electrodes more contact points in the cochlea, and maybe that means more access to sound. Thank you. It would be quite interesting to know what your experiences are with labyrinthitis ossificans. So we came up with this case because the last case that we talked about, the patient that had leukemia actually had a labyrinthitis ossificans noted on the superior canal. His superior canal was ossified, and also the lateral semicircular canal was ossified. And intra-op, we found a thickened, almost ossified fibrotic tissue at the round window, but we managed to pick that off with a pick. We didn't actually need to do a round window drill out or a basal turn drill out. So that's why this topic.
Yeah, Amina, that was phenomenal. Outstanding talk. Wow. I'm really glad we recorded that. Everybody should see that talk. I think that was fantastic in terms of the anatomy and the thought process through it. Fortunately, I don't see a lot of the sequelae of labyrinthitis ossificans because, predominantly you'd expect to see a lot of that in children, with, things like, post-meningitic issues. And so most of the times that I'm seeing issues with this kind of thing, where you're obstructing the cochlea potentially with a fibrotic process or inflammatory process that then becomes ossified, is usually post-traumatic, right? So when you see, typically otic capsule involving trauma of the temporal bone, the clock starts ticking there. And so that's one framework that I typically see it as. And from that perspective, it's really challenging because it really depends on the severity of the trauma. But unfortunately, as you know, the force required to fracture the temporal bone often leads to other issues. And so those patients many times have intracranial complication. And many times they're intubated, they're in the ICU, they may have had a subdural or some kind of evacuation of intracranial bleed. And then by the time you get around to them, and by the time they're actually up and around, I mean, it can be several weeks. It's rare that you can intervene quickly. I've only had a few cases where I had temporal bone trauma, for example. Patient was okay, got the films, obviously, got him cleared for an implant and did that. I had one case where I had a 15-year-old that had a ATV, like a four-wheeler accident, and crashed into a tree and had bilateral transverse temporal bone fractures right through the otic capsules. And fortunately, I was able to get him evaluated, cleared for implants, and then taken the OR within 1 month. And within the 1 month of the trauma, he already had fibrosis in the cochlea. And so those were almost pseudo drill outs. And it was incredible the amount of fibrosis that was already within the cochlea within 4 weeks of time. And so kind of what you described there, I was actually able to open the basal turn near the round window, opening near the round window opening, and then do almost like a pseudo drill out of the fibrosis.
There she is.
Hey, Kathleen, hi. There she is.
How are you?
How are you? Nice to see you.
Barely, but she's alive.
Baby, but I'm alive. Yeah.
It's been a long time.
I'm not on this. Can you see me? Oh, there we
Sort
go.
of, yeah. Yeah.
How are you guys doing?
We're doing well. How are you?
Yeah, good. I just had flu, so I'm kind of trying to work through my flu at work, but otherwise fine. Yeah.
Yeah. Oh, good. We've got to send a search party out after I hadn't seen you in a long time. I was wondering if you'd left the continent or something.
Still here, still active us. I mean, it's been a crazy couple of months. I needed a full year. 2025 and it's time to swap it for a different year because
no kidding. Yeah, I know. Yeah. Well, no, this was a phenomenal talk. We were just kind of wrapping up outstanding talk about this. And I was just saying that most times I see this kind of sequelae after trauma. And this young kid that I operated on, so Amina, what I was able to do was I had to use, as you mentioned, the dummy styleted, the electrode, like the bogey electrode, just kind of like like a test electrode, which is really, so I was able to actually use a styleted kind of a bogey electrode, put it in, and then I shot the X-ray intra-op to make sure it was inserted and it was fine. And it looked like it was probably scala tympani insertion. And then, so after I confirmed that, then I pulled that out. I put the electrode in, which was a styleted cochlear electrode. It was like the equivalent of what we call a 612. I think then it was probably a 512 device. And then I did the opposite side. Then I closed them up and did the opposite ear. Same thing, exact same thing. Fortunately, he did really well with one ear. Other ear, he did not do well. And I think some of that has to do with the concerns you have whenever you're doing a drill out, or even with the fibrosis process within the lumen of the cochlea. You really worry about the neural elements there, how much damage is done. I mean, so it's one thing to get the electrode in, but then how much neural contact are you actually stimulating there? That's the challenge. And I think you mentioned, you get some variability in outcome, and I think largely it's because of that. I've only done one split array one time, which did pretty well with that. And I've only had to do a handful of scala vestibuli insertions where I had to drill, as you say, just anterior superior from the round window, and go directly into the scala vestibuli. But that worked as well. So it's nice to have those options. And like I said, fortunately, I don't see this from like meningitis or inflammation or other inflammatory process so much. I see it mostly secondary to trauma. Yeah. So, Brad, I don't know what's been your experience with this.
I just have one poor fellow come to mind who was in a motor vehicle accident, was quadriplegic, and was in a wheelchair, and something malfunctioned on the lift going up into the van, and he tipped over backwards and had bilateral temporal bone fractures, wound up with cochlear implants. But my experience has been fairly limited, even though I did children in my early practice. I thought that was clearly the best lecture I've ever heard on the topic. I thought that was absolutely perfect.
Thank
Dr.
you.
Segoya, thank you. And the only thing that I could add, I guess, is that actually during my residency, Bruce Gantz, who was at the University of Iowa, devised a little wheel to drill around the first bend of the cochlea, so that if you had a cochlear, you had the first turn of the cochlea was full of truly ossified bone, but the carotid artery was just anterior to that. So you could get around the corner. He had a wheel that had a little diamond on it that would allow him to go around the corner without abutting the carotid. And I saw a couple of complete drill outs where the electrode was kind of laid against the medaillus and then packed in place, but I think those were less likely to do well. I thought your discussion was complete and excellent, and I learned a lot from it. So thank you very much.
Thank you.
Yeah. That was great. Yeah.
I'll see you tomorrow on the Africans tomorrow.
Yeah.
Yeah.
That's great. Excellent.
Yeah. I've got to go and sort out another crisis. So I'm going
Oh,
to
jeez.